Or, if you live with osteoarthritis, you've likely run into one of the most persistent and frankly limiting myths in musculoskeletal health, that deeply ingrained fear that every time you move, you are actively sort of grinding away your joints.
That anxiety is real, and it's a massive problem. Osteoarthritis, or OA, it's essentially the breakdown of joint cartilage, right? And the fear that any activity is making that breakdown worse, well, it prevents millions of people from engaging in the single most effective first-line treatment available, exercise.
Okay. So our mission in this deep dive then is to look at the clinical commentary, the reviews, and really answer that one fundamental question for you.
Does exercise therapy damage knee joint cartilage in individuals with OA? That's the core question.
Let's cut right to the chase. Before we even dive into the how and the why, what did the big systematic reviews actually show about the impact of exercise?
Well, the consensus is pretty unequivocal. The evidence demonstrates that exercise therapy does not harm cartilage structure or quality.
Doesn't harm it.
No. In fact, we see multiple lines of evidence suggesting it might actually improve cartilage quality and health over time.
Wow. That immediately challenges decades of, common sense and even historical clinical advice. It makes you wonder, if the evidence is so clear now, where did this idea that OA is just pure wear and tear actually come from? Okay, let's unpack this. This misconception that's been floating around for, half a century?
It starts with the language we use. You know, culturally, we tend to describe the body mechanically like it's a car that needs new parts, a broken machine.
Right.
So when people hear osteoarthritis, they picture maybe a rusty hinge that is simply worn out from use. And the immediate logical advice seems to be, well, rest it.
So we treat the joint like some fragile object that needs to be left completely still, like don't touch it.
Exactly. And this attitude was reinforced, kind of inadvertently, by early scientific research back in the 1970s. Researchers at the time were doing some really groundbreaking work, looking at how cartilage responded to load, but often using non-human models, things like bovine joints, guinea pigs, rabbits.
Okay, so animal studies. What were they finding in those labs?
They found that when you applied sudden, intense spikes in load or repeated, continuous high-impact doses that were, not natural to the animal's physiology.
Right, like extreme conditions.
Yes, extreme. You could cause rapid changes or even degeneration in the cartilage under those specific conditions.
So if you're a clinician reading that research in, say, 1975, and you have a patient whose cartilage is already a bit compromised, the only responsible action, driven purely by concern, feels like telling them to just stop moving, right, to avoid that load.
That's precisely how the restrictive advice became standard practice. Clinicians told patients, essentially, refrain from virtually all activity, fearing further damage based on these early mechanistic lab studies. And the sources we looked at highlight that this restrictive advice really aimed at avoidance sadly persisted for over 50 years. It overshadowed subsequent clinical evidence that showed movement was actually beneficial.
And a lot of that confusion, as the sources point out, seems to come down to the words we use. Like, when a doctor or maybe a friend tells someone to exercise, the patient might immediately hear, run a marathon, which is exactly the kind of high-impact loading those 1970s studies warned against.
Yes. The ambiguity around the definitions of movement is absolutely critical here. We really need to be clear that not all load is the same, and definitely not all exercise is the same. There are three key terms we should probably define for you, listener.
Okay.
First, there is physical activity. This is the broadest term. It's basically any bodily movement that results in energy expenditure, walking the dog, going upstairs, daily chores. This can include light, moderate, or even high joint loads, just depending on what you're doing.
Okay, so just general life movement. Got it.
Then there is exercise. Now, this is structured, intentional physical activity aimed at maintaining or improving fitness. Think gym routines or maybe competitive training. This can involve high and often physiologically stressful joint loads, especially if you're talking about elite sports.
Right. But the key distinction we were trying to make for someone managing OA is the third type, the sort of prescribed type.
Yes, and that crucial term is exercise therapy. This is where a medical professional steps in. It involves specific exercises prescribed by a healthcare expert, carefully tailored to the individual's current health, their goals, their capacity. And the key thing is that it typically involves low and moderate physiologically sound joint loads, We are talking about therapeutic doses here, not pushing maximal physical boundaries.
That distinction feels monumental. Once you separate that therapeutic controlled loading from maybe reckless or just very intense competitive loading, the fear starts to lift a bit. But now we need the evidence to truly convince the skeptical listener. And here's where it gets really interesting. What happens when patients with OA actually follow these prescribed physiologically sound exercise therapy routines?
Okay, so now we turn to the hard data from systematic reviews, which pool findings from multiple randomized controlled trials, or RCTs, good quality studies. And researchers have used advanced techniques, particularly MRI scans, to look directly inside the joint, see what's happening.
So what did they find? Looking at the structure itself, the size, the shape of the cartilage, did it wear down like the myth suggests?
Well, in a systematic review looking at 9 different RCTs, often involving middle-aged, overweight, or obese female patients with knee OA, they followed these exercise therapy regimens for anywhere from 12 to 48 weeks. The scans showed no detrimental effects on cartilage structure.
No negative effects at all.
None reported consistently across the studies. This included no negative changes to morphometry, which is, the thickness and volume of the cartilage.
So it didn't shrink or get thinner?
Correct. And also no negative changes to morphology, which means the presence or progression of cartilage defects or fissures. It didn't seem to develop new cracks or make existing ones worse either.
Okay. And what about the quality, like the cushioning aspect?
Right. The quality of the cartilage, measured by components like glycosaminoglycans and collagen, which give it that elasticity and cushioning that was also not harmed. And interestingly, in some cases, particularly maybe in younger or healthier weight patients, some studies even noted potential improvements in quality markers.
Okay, that's structure. What about inflammation? Because if movement is damaging the joint even slightly, surely we'd see the body registering that damage with some kind of inflammatory response.
That's a great point. And another review of 12 RCTs looked specifically at those molecular and inflammatory findings. They found that therapeutic exercise, whether it was aerobic, strength training, or a combination, did not induce systemic inflammatory responses. Markers like C-reactive protein or IL-6, which can signal joint stress or inflammation, they didn't elevate. Neither did the molecular biomarkers associated with destructive cartilage turnover.
That seems like pretty strong evidence against long-term prescribed damage. But let's play devil's advocate for just a second. If I have OA and I decide, okay, I'm going to start jogging or cycling, doesn't the cartilage feel pressure? Isn't even a small, maybe transient change in cartilage volume still a step in the wrong direction?
That's a very fair question. And the sources do acknowledge that activities like walking or cycling can cause minimal transient changes to cartilage structure immediately after the activity, like right after you stop. But these are seen as momentary physiological responses, not long-term damage. It's like your muscles being temporarily fatigued after a workout.
Okay, so temporary, not permanent damage.
Exactly. And interestingly, the research found that even when looking at higher impact activity like, say, jumping, which might cause some pain or discomfort, especially initially, it did not seem to cause detrimental structural changes even in patients who already had mild radiographic OA. So the evidence really helps differentiate between momentary discomfort, which might happen, and actual tissue damage, which doesn't seem to happen with therapeutic exercise.
Okay, we need to give the listener a kind of mental model, something that helps them internalize this counterintuitive idea that loading is actually good. And for that, the sources talk about the powerful sponge analogy.
Ah, yes, the sponge analogy.
Yeah.
This is often the aha moment for people, and it's great for clinical communication. So cartilage is unique tissue because it is avascular. That means it has no direct blood vessels feeding it oxygen and nutrients like other tissues do.
Right. So how on earth does it get the building blocks it needs to maintain itself or get rid of waste?
That's where you use the sponge analogy.
Yeah.
Picture your cartilage like a sponge sitting in a pool of lubricant and nutrient-rich fluid that's the synovial fluid inside your joint. To get fed, that sponge must be squeezed and then allowed to soak things up again. Repetitive loading like walking, bending, cycling acts like squeezing the sponge. When the load is released, the sponge then soaks up that synovial fluid.
Bringing in the good stuff.
Exactly. Delivering essential nutrients to the repair cells, the chondrocytes, and at the same time flushing out metabolic waste.
So loading isn't the weapon destroying the joint. It's actually the pump delivering the medicine, the nutrition.
Precisely. In fact, this beneficial load, this pumping action, can actually stimulate those chondrocytes, the cartilage cells, to produce crucial components like collagen and aggrecan. These are the things that contribute to the resilience and quality of the cartilage. So the load is actually a necessary biological stimulus for maintenance and potentially even improvement.
Okay, given this consolidated, half-century-old body of evidence confirming safety and benefit, why are we still seeing pharmaceutical interventions and surgeries often prioritize over-prescribed exercise therapy? This feels like a huge gap between the evidence and practice.
It is a huge gap,
Yeah.
and the sources state pretty clearly that while, yes, research implementation naturally lags, another 50 years cannot pass before this becomes standard practice everywhere. Exercise therapy is globally recognized as the recommended first-line treatment for knee OA. It's in major medical guidance like the NICE guidelines in the UK, for example.
And the cost of not acting is high, right? Both for the patient's overall health and probably the healthcare system's bottom line, too.
Exactly right. We're not just treating a knee in isolation. Exercise is considered medicine for at least, I think the number is 26 chronic conditions, many of which overlap with OA patients, providing benefits like improved mood, better cognitive function, reduced blood pressure, the list goes on.
Yeah.
So the failure to implement this low-risk, evidence-based first-line treatment is described in the sources as inefficient, unethical, and potentially harmful. And furthermore, effective exercise therapy offers significant potential cost savings by delaying or perhaps even preventing the need for expensive total knee replacement surgeries down the line.
So how do we move forward? What's the concrete approach suggested for health professionals and maybe even for patients advocating for themselves to get past this fear of movement?
The sources suggest a pretty straightforward three-step educational strategy, really focused on communication. Step one is assess patient beliefs. Clinicians must proactively ask about the fear. Are you worried that moving your knee is wearing it down? You have to bring the myth out into the open.
Right. You can't treat the joint until you treat the fear associated with it.
That's right. Then, step two, address misconceptions. This is where the education piece comes in, using tools like that sponge analogy we just talked about. Clarify the difference between damaging high loads and those physiologically sound therapeutic loads. Reassure them that while temporary discomfort might occur, it will not cause long-term structural damage.
Makes sense. And step 3 is about making sure the plan actually sticks.
Yes. Step three is to promote exercise therapy using established behavior change strategies. Things like collaborative goal setting, making a concrete action plan, maybe self-monitoring progress. These strategies are proven to improve patient adherence and success across pretty much all chronic conditions, not just OA.
This has been incredibly clarifying. I think the central takeaway for you, the listener, really has to be that prescribed exercise therapy is not only overwhelmingly safe for osteoarthritis, but it's actually a necessary biological stimulus for cartilage health. It acts like the joint's delivery truck for nutrients. Movement is medicine.
So what does this all mean? Well, the sources really give us permission to evolve our beliefs based on new information, which is fantastic. Science moves on. But we must end with perhaps a slight note of caution or maybe realism. While the safety of therapeutic exercise is really well established now,
Yeah.
the level of certainty regarding the positive structural effects, so the actual measurable improvement in cartilage thickness or quality, that's still considered low by the current highest standards of evidence.
Okay, so safe, yes. Proven to rebuild cartilage structurally. The jury is still out on the strength of that evidence.
Precisely. We need more high-quality research specifically on those positive structural outcomes. But the safety data is strong, and the overall functional and systemic health benefits are absolutely overwhelming.
Yeah, absolutely.
And this raises, I think, an important final question for you to consider. If future evidence does continue to confirm that prescribed exercise can structurally improve cartilage, how do we finally bridge that huge chasm between knowing the science and ensuring every single person with OA has timely, affordable access to this effective, low-risk first-line treatment?
The gap between evidence and implementation really remains the crucial challenge ahead. A fantastic deep dive into the evidence, though, confirming that movement truly is medicine, even for compromised joints. We definitely encourage you to continue exploring the resources we've discussed on this really critical topic.